So, without further ado, it is my honor to introduce Mei Wa Kwong. She's a JD with over 2 decades of experience in state and federal policy work. She's the executive director for the Center of Connected Health Policy, the federally designated National Telehealth Policy Resource Center. May has written many policy briefs, crafted state legislation, and led several coalition efforts on a variety of issues. Ms. Kwong has published articles on telehealth policy. She's recognized as an expert in her field and has been consulted by state and federal lawmakers on telehealth legislation and policy. May is a graduate of the George Washington University of Law School. So, without further ado, I'm going to hand it over to May to take it away.
Thank you, Nikki, and thank you to NRTRC and BHI for having me here. I think this may be like my third go around with you guys, so I must be doing something right if you've asked me back. So, and also thank all of you for attending this talk today. As Nikki mentioned, policy is very dynamic at this time, especially around telehealth. So, be mindful of like what I tell you today may change next week. That's just simply the environment that we're in right now. But I will hopefully be able to give you like, kind of a good overview of what our current state is and maybe a little bit of insight on what it could look like in the next couple of weeks here. Like Nikki, I also need to do some disclaimers, and this is kind of a repeat of what she said earlier, but just to drive this home, any information provided in today's talk should not be considered legal advice. It is strictly for informational purposes. CCHP always recommends that you seek out legal counsel if you are interested in a formal legal opinion. And if I happen to mention a company or show a picture of a product, know that neither I nor CCHP has any type of relationship or affiliation with such a company. Bit of background about CCHP, just very quickly, if you're not familiar with us. We actually started off as a California telehealth policy organization as a program underneath the Public Health Institute in 2009. An opportunity to become the federally designated National Telehealth Policy Resource Center became available in 2012 through funding from HRSA. CCHP applied for that. We got that funding, and we've been serving in the capacity as the National Telehealth Policy Resource Center ever since. We also work with a variety of other funders and partners on a state and federal level on sort of more discrete projects related to telehealth. They could vary widely from like, an issue brief to a little bit more of an in-depth research project. We also act as the administrator for the National Consortium Telehealth Resource Centers, which I will get to in a second. And we convene a group in California, specifically called the California Telehealth Policy Coalition, that is focused specifically on state California telehealth policy. I mentioned the consortium a second ago. This is actually made up of the 14 telehealth resource centers that all receive funding from HRSA underneath this program. There are 12 regional resource centers. You have the great Northwest regional one that Nikki represents, but there are 11 other ones that represent or cover specific states. So I always like to say that if you are interested or have a question around telehealth, please reach out to your regional telehealth resource center first. They are some of the most knowledgeable folks around telehealth in the country. So they are your great first stop if you have questions. There's also 2 national centers. CCHP is the one on policy, and the other one is on technology based out of Alaska. And we all work very collaboratively together, so much so that we created this umbrella entity called the National Consortium Telehealth Resource Centers, where we pull a bit of our resources together so we can make sure that we're not duplicating work or duplicating materials that could have like applicability like across multiple states or across the country as well, just to make sure we can like work a little bit more efficiently with our federal dollars and work more efficiently for you guys as well too. As I said, I urge you to reach out to your regional telehealth resource centers, but if you reach out to anybody related to the TRCs or working at the TRCs and they're not the right person for you to talk to, they will direct you to the right place. So it's again a invaluable resource for those who have questions around telehealth. So for today, I like to cover a couple of things. First, what's the current status of federal Medicare telehealth policy? And I was asked really to kind of focus in primarily on what's going on the federal level. And that's, to be honest, kind of where the most dynamic changes are happening or most uncertainty around the policies. I'm also going to cover, a what if. what if a certain scenario happens, and that scenario is reverting back to permanent Medicare telehealth policy, and like what would that look like? And then I also want to go over another federal issue that's out there as well too, and that's about telehealth and using to prescribe controlled substances. And then very briefly, I'll touch upon what's going on in the states. As I said, it's a little bit more dynamic on what's going on in the federal level as far as telehealth policy is concerned, but we still have to be mindful of what is going on the state level as well too, and what may be the impacts of what happens on the federal level as far as like what states decide to do around their telehealth policies. So first off, CMS and Medicare and telehealth. Now, I do social media. I do look primarily just to monitor and look at it. So some of you may have seen something last night or gone to the CMS Medicare website where they said like, oh, there will be no more telehealth in Medicare come April 1st. That's a little bit of too broad of a statement. So yes, right now, what we are currently under are temporary telehealth waivers for Medicare. So this is the allowances, the allowed services to take place really in any location, and you have like a broader panel or a broader list of providers who can provide those services and get reimbursed by underneath the Medicare program. They use telehealth, those types of things. And those are temporary waivers. And yes, they are set to expire March 31st, 2025. Now, the question is like, is anything going to be done to extend them? So if you saw some of those social media posts that said like, oh, they will end and telehealth will disappear completely April 1st, that's not quite true. What will happen is the waivers will disappear, and what will happen is we will revert back to permanent telehealth policy in Medicare, and I'll go dive a little bit deeper into that. But right now, we are still underneath this sort of temporary waiver period. And what that means is there are certain requirements, certain restrictions underneath the permanent telehealth Medicare policies that are waived. They're temporarily suspended during this waiver period. And one of the big ones is the geographic requirement. Now, I know a lot of people became involved in telehealth during the public health emergency, so they may not be familiar with like what the permanent policies look like, but the permanent policies had a geographical requirement on there in that you had to be in a certain geographical place, which was a rural defined place, and they had a specific definition for rural. So that was waived temporarily. Some of the other things that were waived were the list of providers. On any permanent policies, it was a specific list of providers, so they waived that, and certain site requirements or certain site limitations as well too. So all of these things have been waived, and I put a list here of some of the major ones, and that is in place until the end of March. Now, some of the other things that are, waived or have been delayed may not necessarily end in March. And the reason for that is like these were regulatory changes that CMS did not have to wait for Congress to like have permission to like waive. So a lot of the other ones that I just talked about, like the geographic limitation, the site limitations, those are things that are embedded in federal law. So it really does take an act of Congress to delay them or change them. It's not something that the administrating agency, which is CMS, can take care of. But there are other things that really are underneath CMS's control, and they were able to act on them without waiting for Congress to like give them permission or for Congress to act on it. And some of those things are the big one is like related to the list of eligible services that you can provide via telehealth. There's like a kind of minimum requirement underneath federal statute of like what services should be recovered, but then there's a line in federal law that says, or any other type of service that the secretary deems should be covered as well too. So that gives CMS a lot of flexibility in saying like these services can be provided via telehealth. So that's one thing that is not sort of beholden to that March 31st deadline, because that is a power or flexibility given to the administrating agency. But some of those other major things, such as the geographic requirement, the location requirement, the type of provider to provide the services, They are typically something that you got to wait for Congress in order to allow. I'm going to put one caveat on here, and this is where we start getting like a little bit complicated on things, and you start getting into like nitty gritty details. Typically, I would have said, like about 2 or 3 years ago, the list of eligible providers is something that Congress would need to change, but there's been a little bit of action by CMS that it's kind of a bit of a workaround. We'll just call it that for now. And I'll explain that a little in a moment there. But typically those are things you got to wait for Congress to like act for them to like do something. The deadline's March 31st. So we got to see what happens here. So what could happen? Like March 31st rolls around, what's going to happen here? Well, there could be an extension of the waivers. What has happened in the past for like these waiver extensions, which the one that made it to the March 31st date, the one that enacted that happened in December of 2024. It was underneath the continuing resolution. There have been previous extensions of waivers before, and they've excuse me, essentially have happened within budget appropriation bills or bills related to like financing the federal government. It's been like a policy item that's been stuck into like those bills, into these larger bills. Right now, congressional members are discussing the budget and another continuing resolution. So it is quite possible that there could be another extension added into like those discussions, like they did back in December of 2024, to extend the telehealth waivers. So that's one potential outcome. Another potential outcome is things do expire. No, there's no action by Congress, or they aren't able to like do something in time, and we do hit the deadline. Doesn't mean they can't go back. Even if we like hit the deadline, March 1st or April 1st rolls around, and we revert back to telehealth permanent policies underneath Medicare, it does not mean they can't go back, or they can't go forward and say like, at a later time saying like, okay, we're going to do X now around telehealth. So that's always a possibility, but there would be that gap there of like where we're underneath permanent Medicare telehealth policy. Then the third option is like, it's kind of a hybrid possibly, or they make changes. So the first option where I said like they extend the waivers is like, it's basically they just move the date, they don't make any other changes. But what could also happen is like, well, they extend the date, but they make changes in there, such as they extend the date for some things, but they don't extend the date for others, or they add other conditions on there. Things like that could happen as well too. So these are really kind of like the broad options here. The first one, self-explanatory. They extend the date for a certain period of time. The last one, we really don't know what might happen. Right now, I do know this is a topic among congressional members, but I have no insight as to like where this discussion is landing. Like, are they talking about just extending the waivers, or are they thinking like more changes? Well, what's going on there? So I don't really know which of these options are going to like actually be, or are taking the leads, have the best odds of happening. The one that we can like talk about now, and what that may look like, and which I think might be helpful for folks, because again, probably some of you came into telehealth like during the waiver period, so you may not be as familiar with like permanent Medicare telehealth policy. But even if you were, it looks very different than what it was pre-pandemic as well too. So there have been changes along the way. So if we do land into a permanent telehealth policy scenario come April 1st, it's going to look different than what some people may have experienced before the pandemic, just because of certain policy changes that have happened over the last couple of years. So we'll get into like that, like what happens then? What does it look like if we revert back to permanent policy? So the way that I think it's kind of easiest to approach this is to understand like telehealth reimbursement policy, because this is what we're talking about. We're talking about Medicare coverage and the reimbursement policy. There's usually 4 issue areas that are impacted: service, location, modality, and provider. So by that, I mean, you may have a policy in a Medicaid program that says, oh, this Medicaid program will reimburse for mental and behavioral health services. so your services. When the patient's located in a clinic or hospital or doctor's office, location of the patient, and the service is being provided via live video, the modality that's used, and it's being provided by a psychiatrist or social worker, the type of provider is being used. And if you look at like telehealth reimbursement policies, you kind of see that this is where they kind of like build the policies around, like these four specific issue areas. And Medicare is the same. They build a lot of their policies are built around these four issue areas. One caveat is that Medicare has a separate section for technology delivered services that they do not consider telehealth. These are their communications technology based services. And this is where your remote patient monitoring is located in. But you also have some live video, some store and forward services located underneath here as well. So if you're talking about like e-consult, e-visit, that's under CTBS. And CTBS services in Medicare, CMS's eyes, is not telehealth. So that means they are not underneath those telehealth waivers or those telehealth restrictions in statute here. So if come April 1st, the telehealth waivers do expire, those CTBS services, they're not impacted at all because they were never part of telehealth where as far as CMS was concerned. So I just want to point that out as well too, is that when you're talking about Medicare, you are talking about two separate buckets of technology delivered health services. One is telehealth that has all these restrictions and you have the waivers right now. And then the other one is communications technology based services, which uses telehealth technologies, but because it's not considered telehealth by CMS, don't face those restrictions, did not have to really worry about the waivers for the most part. So just keep that in mind if you are like a practitioner who is perhaps doing more communications technology based services for Medicare as opposed to like telehealth services. Now, when you consider policies as well too, you cannot take a policy in isolation sometimes. Sometimes the policies are interconnected or they're impacted by each other. And I'm telling you this because this is going to become important a couple of slides down there. So for example, if you look at something like, oh, this Medicare policy says these services can take place in the home. So that may not necessarily just impact, the location of the patient, like the impact of like that particular policy may not just, be centered on like just on the location issue. It could have impact on some of the other policies, such as like, modality used or services that are eligible or type of practitioner that's eligible. So I want you to keep that in mind, that there are times where your policies will overlap with each other or intersect with each other, where they can kind of change how that policy's impact can be and may go beyond what you think of, and it's not what you're looking at on its face of like, oh well, that policy is just related to like the patient location and it means they can do that in the home. It could have other effects too, and just keep that in mind when we get to a couple of slides further down here. So what does permanent policies look like without the extension? It's pretty limited. And that is like the big thing. If like the waivers expire, is that we essentially go from this of like what was allowed and covered by Medicare to kind of like this. So it will significantly shrink. It does not mean it's eliminated. And that was like one thing that I was looking at on social media where people were saying like, oh my God, Medicare will just stop covering telehealth. No, they're not going to stop covering telehealth delivered services underneath Medicare if the waivers expire, but they will shrink significantly. So that is like a significant change if the waivers expire, but it does not mean that telehealth becomes like not covered at all underneath Medicare. So what happens? Originating site, the patient location starts becoming important again. You have like that rural restriction, or patient is in a non-metropolitan statistical area. They have to be like in that certain type of geographic location in order to qualify, or in order to have the telehealth delivery services be covered by Medicare there. There are some exceptions, and this is where it gets complicated. So there's that policy there, but over the years, CMS or Congress has actually built in certain exceptions to these requirements. So, for example, for the rural geographic requirement, there are exceptions to that, and they apply to when there's treatment for stroke, treatment for end stage renal disease, and for some mental health services, which is important to this group, I know. Um, Limited list of eligible providers. Like again, our list was like this. Basically, it was like all eligible providers that need Medicare, and it comes down to like a specific list. Uh, Again, there's like certain exceptions here, and this is the one where I said that there was some action by CMS that was interesting that kind of broadens it slightly, and I'll get more into that in a little bit. Um, Limited list of eligible facilities for originating sites. There's like basically you would need to be in some type of healthcare setting, such as like a doctor's office, a clinic, a hospital. Again, see, there have been limited exceptions built in over the years to the permanent policies, allowing the home to be an eligible originating site, but only for certain services. Again, end-stage renal disease and treatment for substance use disorder. And if you have a co-occurring mental health disorder with that substance use disorder, that also can be treated in the home. Audio only. That has been basically a product of these temporary telehealth waivers over the years. But again, with some actions with CMS, they've built in some exceptions. We'll get more into that in a moment. And then for mental health, taking services taking place in the home that are not connected to SUD, not connected to substance use disorder, that is another exception that was built in. Yes, you can have mental health services, some mental and behavioral health services take place in the home without meeting the geographic requirement and without having to be a co-occurring condition with a substance use disorder, but certain conditions apply. So what do all these exceptions look like here, and how did this all happen? Well, for the list of eligible providers, I said earlier, if you talked to me about 2 years ago and said like eligible providers list, what would happen? And I would say like, you need Congress to change that. That's written into federal law. Interestingly, in the last physician fee schedule, though, for those who don't know, physician fee schedule are the big set of policies that CMS comes out with every year, and they're the regulatory and their administrative policy, so they don't have to go to Congress to do that. It's underneath their powers as an administrating agency to do. They come out with them every year. It usually comes out, the draft proposal comes out in like around July. There's like 3 months or 2 months to like provide public comments, and then they finalize them like around November. And unless they have like a different date associated with them, they go into effect the first of the following year. So the ones that they released in 2024 went into effect January 1st. Unless they were delayed, for example, by like the waiver or something. So I said earlier that changing the list of providers would require an act of Congress if you had talked to me like maybe about like a year and a half ago. But last year, CMS said, you know what? The way the federal law is written and the way this particular policy is written in federal law, it says, oh, eligible providers are practitioners defined by these other sections of federal law. And they go there and you'll see like a list. It's like doctors, midwives, etc. CMS said that federal law specifically called out those practitioners. So those policies were really, those telehealth policies were meant to impact those practitioners that they specifically called out in federal law, which means we at CMS can do it for everybody else then. And we are going to decide that at least for the rest of 2025, we're going to allow FQHCs and RHCs to continue to provide telehealth services throughout the year. So what does that mean? So if March 31st rolls around, there's no extension to the waivers, and April 1st happens and we go back to permanent telehealth policies because of this regulatory change in the physician fee schedule by CMS that they did for 2025, at least for FQHCs and RHCs, they can continue to provide services via telehealth, and Medicare will cover that. So that is where I said that it looks like it was a statutory change that needed to happen, but CMS examined that and said, like, we interpret it as those telehealth statutory provisions applied to those practitioners that were named in those provisions. FQHCs and rural health clinics were not named in those provisions, so we can decide how telehealth can like work for them. Nobody's challenged that, so I'm assuming that that will continue throughout the year if like the temporary extensions do expire. Like at least FQHCs and RHCs can continue to provide telehealth delivered services underneath Medicare for that year. Now they did say just through 2025, so 2026 is a whole different story. We'll have to see what happens there. But at least for like, what is that, 9 months that would be left to 2025 after the expiration date, FQHCs and RHCs can continue to do that. So that's like an exception there, very different than what permanent policy pre-telehealth waivers look like. That's where I was saying like there's been all these changes, and even if you were like familiar with like original permanent telehealth policies, there's been some changes over the years and it can get a little complicated. Audio only. So the audio only stuff was really things that were in federal statutes, specifically audio only stuff, where they specifically said something about audio only. It was put into federal law by all of those like pieces of legislation that dealt with like the waivers. Like they said like, oh yeah, an audio only can continue through like whatever the deadline they had for that waiver extension for that particular bill here. Again, CMS using their regulatory powers expanded that a little bit by doing a redefinition of a term. So underneath the telehealth policies in federal law, they say, well, what is telehealth? And telehealth is like delivered through a telecommunication system. And in federal law, telecommunication system is not defined. So it leaves it up to the administrative agency to define it. Now, over the years, this all happened way before the public health emergency. CMS put the word interactive in front of it as well too, so that kind of eliminates your storing for things. But their term that they use is interactive telecommunication system. In the last couple of years, CMS has added audio only to that definition as well, but they put caveats on it to like, as far as like how much or where you can use that audio only. But they've expanded the audio only portion a bit too by doing this redefinition. And that's something that they've also done in other areas there by expanding policies a little bit without waiting for Congress by doing a redefinition of a term that's not defined in federal law. And that's left to the agency again to redefine things. And then for mental health services taking place in the home and not meeting geographic requirement or, falling underneath like some other exception there. So CMS has basically put in the exception there where, you need to have that prior in-person visit and then like a subsequent in-person visit every 12 months. They have done like a couple of exceptions to like that follow-up 12-month visit by saying that, if the patient and provider determined that it could be detrimental to the patient of like, that there's like an interruption in their services, like trying to meet that in-person service. So that's like a more focused exception, but again, an exception that CMS has made to really kind of, I think, lessen as much as they can some of this disruption if like the waivers expire. And that prior in-person visits for the mental health, that was part of the waivers as well too. That was specifically a congressional delay where they said like, we're delaying that because that's actually in federal law requiring that prior in-person visit for a mental health visit if you're trying to do the service in the home and not meet one of the previous exceptions and you're trying to like not meet the geographic limitation as well too. So that's like a more focused exception that CMS has done. So what does mental health under the permanent telehealth policy looks like? What are some of like the allowances? And this is where we get back to why I spent so much time saying policies sometimes overlap each other or they interact with each other and they create a sort of difference in like how you may interpret it on its face, like the impact of that policy. So underneath permanent telehealth Medicare policy, I talked about it in that, if you were diagnosed with a substance use disorder and you had a co-occurring mental health condition, you can be treated in the home and you don't have to meet the geographic requirement. That's actually something in federal statute there. So that was not like a CMS kind of reinterpretation or redefinition of something like that. That's something that's like in federal law. So that's fine. You can do that. We also talked about that the other exception is that you can avoid the geographic requirement and not have like a substance use disorder diagnosis and still be treated for mental and behavioral health services in the home if you have that prior in-person visit. And the prior in-person visit requirement is that it needs to be within 6 months before the telehealth visit starts, and it needs to be a service given by the telehealth provider to the patient that was covered by Medicare or would have been covered if the patient would have had Medicare coverage at that time. So those are like kind of like the flexibilities given to the mental health services outside of like the even more narrow scope of original telehealth permanent policies underneath Medicare, which says like, oh, you need to be in this geographic location, a specific geographic location. You need to be in like this type of healthcare facility, da da da. This is like kind of like the expansion that's given a little bit for mental and behavioral health services. The other sort of element to this is where audio only services come in. And this is where CMS did a redefinition of interactive telecommunication system. And this was happened with the 2025 physician fee schedule. And what they said was for audio only, you can use it for telehealth services when it's furnished to a beneficiary, a Medicaid enrollee in their home. If the distance side practitioner was able to use like live video essentially, but for whatever reason, like the patient wasn't able to or did not want to use live video. Now, a lot of people have looked at that and said, oh, that's great. You can like provide all these services via audio only. No, this is where those policies overlap. And like this is where the policies intersect with each other and they may create a more narrow environment than what you look at. On the face of this, it does kind of look like, oh, you can provide almost any services then in the home via audio only to these enrollees, Medicare enrollees. No, because you need to meet two requirements in order to use the audio only. First, the patient needs to be in their home, and second, you need to the practitioner needs to have been able to use live video, and the patient, for whatever reason, because they weren't able to or did not want to use live video. Second requirement, of like the practitioner was able to use live video and the patient didn't want to use it or wasn't able to use it, probably not an issue. Probably like a requirement easily be able to be met. However, it says the beneficiary needs to be in their home. So going back to our permanent policies, what services can take place in the home underneath Medicare policy? It was a limited list. It's end-stage renal disease, some mental health services if they meet certain requirements, and substance use disorder with a co-occurring mental health. So on here, on the face, looks like it's broad policies, but because of that requirement, the beneficiary needs to be in the home, it's actually a much smaller list of services. So that's why I was saying that be careful when you look at a specific piece of policy on the face of it, it may look broad, but then you got to think, well, is there other policies that might impact some of the things in here? And it's that beneficiary in their home. When they're in the home, what Medicare services are covered when the beneficiary is in the home? And it's only that very specific list. So I know that has been a source of confusion there. But that has been our interpretation of it. This has not been activated by CMS because of the waivers, but just how they did sort of like the telehealth services list and like what they were doing around audio only, you see it's like really the audio only codes were really just around some of the mental behavioral health services. That's probably what they were aiming for, is like kind of more of that narrow allowance for audio only here if the waivers were not being continued. So what else is going on the federal level? I know I am going long, so I do want to leave time for Q&A. I'm going to go through these next couple of things pretty quickly, and they should be pretty quick as well. Prescribing of controlled substances. Most of you probably know there have been also extensions by the DEA on how you can use telehealth to prescribe controlled substances without falling into one of the narrow exceptions of doing that without having a prior in-person examination by the telehealth provider of the patient. That's been extended until the end of 2025. Uh, I don't know for certain, but this is just my guess. I'm not quite sure that the DEA is going to want to extend that any further. But we are underneath the new administration. So some of the stuff that I'm talking about now actually was underneath the previous administration that it came out under. I don't know where the new administration may actually fall on this stuff. So they may pull back some things, maybe they will extend things, but right now I'm going by like the stuff that's been out there, but it is stuff that was like released by the previous administration. Couple of things, two things were finalized again with the previous administration. That is a expansion of buprenorphine when using telehealth and continuity care when using telehealth for Veterans Affairs. These are final rules, so it's permanent policies. They were supposed to go into effect this month. That was pushed back and delayed until March 21st of 2025. The one that's out there right now that's just a proposed rule and is still open for comments is the special registration for telehealth. And for those who are familiar with this issue, one of the exceptions of using telehealth to prescribe a controlled substance was that the DEA would create a registry, which the concept was you're a practitioner, you get on that registry, you're all fine. You can go ahead and prescribe without falling into having meet one of the narrow exceptions there. The DEA finally put out regulations of like what this registry will look like, what will be the requirements, et cetera, et cetera. It's a proposal right now. Comments for that are due March 18th. So if that is an important issue for you, really read through that because it's highly detailed. Read through that and provide comments to the DEA. Again, I will say this did come out underneath the previous administration. So I don't know if this current administration wants to stick with it or not, but that's the thing that we have out there right now. State telehealth policy. A lot of people have said like, so what's going to happen if like if the Medicare waivers expire? What's going to happen on the state with Medicaid and like state telehealth policies? Probably not much. For one thing, a lot of states have a really kind of settled on like their post PHE type of policies. They've been settled for a couple of years. There are some that have still done extensions, but they haven't necessarily tied it to the federal deadlines as well too. Not to say that it's never going to have an impact on the states. It's just not going to have an immediate impact of like, oh, it's only changes on April 1st for the states. There is like some things that, the states may want to like duplicate that the feds are doing on the federal level. But again, it's not going to be that immediate impact of April 1st. Something changes on the state as well too. Washington State, just really briefly, just to give you a state example to look at. So what does Washington State Medicaid does? This is very high level. So there's like a lot of detail involved in here. And I would say go to CCHP's policy finder if you're interested in digging into the details. But essentially what Washington State does is they do reimburse for live video, some store forward and route patient monitoring, some audio only. They have specific instructions for billing, depending on what type of entity you are, what type of practitioner. So you got to like look at those manuals as well. The location can be in a home or, and interesting, they say any location determined by the individual receiving the service. So that's like a bit broad as well too. And it allows audio only for certain services, but require additional items such as, it's only for an established patient-provider relationship. So slightly different than what we've seen with some of like the other like Medicare policies around audio only. But this is like high level Washington State. Now, comparing it with like permanent telehealth policy on the Medicare side and what Washington State does, you can see Washington State looks pretty kind of broader than what is being done with like permanent Medicare telehealth policy. And that's really what you're going to encounter with like the majority of states. You will find like at least their Medicaid policies are much more broad than what you will see underneath the permanent Medicare telehealth policies. And also some of the permanent Medicare telehealth policies, as we've just been discussing, can get kind of complicated with like their exceptions as well too. So all that just to say like, if you're more Medicaid kind of patient panel, that's a little bit more stable because a lot of them have kind of already established like this is for the most part what we're doing. They are making tinkerings every year. There's always a possibility of them tinkering around with some policies, but you don't have that, oh, there's a deadline looming. Like for the most part, sometimes they do stick a deadline on something, but you don't have like, oh, there's this March 31st, 2025 deadline looming like you have for like Medicare. That is about it. I know I went really long, and Nikki or Cara, I know you guys want to go through the other slides, and I'll take a look and see like what questions are there as they go through that. Thank you. So I'm just going to run through these quickly. A lot of these I think I answered in the presentation, so I'll just briefly touch upon there. Yesterday, I heard rumors that telehealth is going to be disbanded from Medicare. This may be political spin. I realize current provisions are set to expire March 31st, but is there any credible information or thoughts you have concerning upcoming changes? This particularly alarms me related to telehealth behavioral health as we serve so many kids who cannot physically travel. So as I mentioned earlier, I think that was just I saw it on social media. And social media, it was basically X. You're limited in characters, so I think they were just doing like a shorthand of saying like, oh, it ends completely. It's like as I talked about in the presentation, it's not going to end completely. It will become like narrow. It will like narrow down, but it's not going to end completely. And as I mentioned, I'm not privy to what they may be talking about right now, so I don't know. I don't know which of the options that they're going to go for, whether it's an extension, whether it is just going to expire, or whether it's like a hybrid of things, like certain, maybe they let certain things expire and continue other things, or they put other conditions on there. So it is a wait and see. If waivers expire relating to Medicare, what will happen with private insurances and state laws? Will they automatically change with the waivers expire, or will they make their own changes in a piecemeal fashion? As I mentioned earlier, for the most part, state telehealth policies are probably not going to change. I am not familiar with anybody tying any of their policies specifically to this waiver deadline now. As I said earlier, there are some states like Maryland, I think, they have a deadline as well too, but they pushed it out to like I think 2026 at this point. So they're on like their kind of their own track. So nothing's going to happen immediately on April 1st if these Medicare waivers expire. Now down the line, it could. I mean, it could, because you may have somebody changing their policies there. But for the most part, everybody else should remain stable. It's really like that Medicare policy. And also prescribing controlled substance, because that only lasts until the end of 2025 as well too. Do the geographic requirements apply to companies that clients choose to administer their Medicare, such as Blue Cross? I think you're talking about Medicare Advantage plans. The way Medicare Advantage plans work is that they need to do the minimum of what original Medicare telehealth policy is. They can do more if they want. That flexibility has always been there for Medicare. Well, not always, but it's been there for even before the telehealth waivers, before the pandemic. They've had that flexibility to do that. It's just that it's not necessarily covered in their what they get from the federal government to do Medicare Advantage plans. So that kind of like restricts them in that making that decision. But a Medicare Advantage plan can do more with telehealth than like that original Medicare telehealth policy, permanent policy there. I don't know which slide you're referring to about the asterisk. If Julia Otero, if you want to follow up with that with the specific slide number or the topic on the slide, I can like answer that. So I don't know offhand which one you're referring to. Is there a full list of CTBS services? Curious about the follow-ups count as. There is a fact sheet. It's kind of an old fact sheet on communications technology-based services, but I don't think there's necessarily a central location of what all those are. And also, CDBS services is a big umbrella. It includes all the communications technology-based services, and then you have kind of like subsets of them. You have remote therapeutic monitoring. You have like e-consult. You have e-visits there. So it's kind of depending on like what you might want to see in that or interested in like that particular type of modality or type of area there. Are there separate exemptions for telemental health? If so, I kind of went through that in the presentation. Who are the people making the decisions to maintain telehealth, and how do these how do those of us providing the service provide feedback and give recommendations? How can we make our voices most effective? You got to talk to your congressional members. So right now, a lot of these changes, we're just waiting to see what Congress is going to do. So you need to speak to your representative about that. Mental health is still carved out from all these rules, correct? We are seeing patients in homes across Montana, Idaho, and Arkansas, and believe we're still okay regardless of the waivers at this point, but wanted to confirm if you meet certain exceptions, like I talked about. So, depending on what you're doing, well, first off, if it's Medicare, it depends on what you're doing. Again, if you're treating Medicaid patients, that's a whole other story, or a private payer or commercial payer. For Medicare, it depends on what you're doing and what you're doing for these patients. If they are being treated for substance use disorder and they got a co-occurring mental health disorder, you should be fine. They can still do it in the home, and you don't need to meet like any other type of requirements and everything. But if you're just treating them for something and it's not co-occurring with a substance use disorder, then you need that prior in-person visit. So it's going to depend on like what their scenario is. How do we find out rural location lists for our states? So there is a telehealth eligibility analyzer that is on the CMS website. I don't have the exact link right now. You could just literally just type into Google CMS telehealth eligibility analyzer, and it will bring up a page where you can type in the address of where the patient is going to be located, and it will tell you whether you qualify underneath the permanent policy. Remember, right now we're underneath the waiver situation, so that eligibility analyzer should not be applying. But if again the waivers expire, you're going to have to go to that, type in the address, and see if like your site is going to be eligible. Impact for pediatrics. Do you think Medicaid will follow similar changes? Not immediately. It's possible. It's possible they may copy things such as, oh, you need the prior in-person visit type of thing happening, or oh, we're just going to limit audio only in how you provide services. They kind of some of the Medicaid programs kind of already do, just limiting it to mental health. Again, most likely not going to happen starting April 1st for the Medicaid programs, but I'm not going to discount that they may decide to change policies down the line there. Can you provide any education on CMS requirement for enrollment of providers seated home residing location versus the patient location? I'm not quite sure I understand that question. One thing that was a CMS administrative change that is supposed to last through 2025 was that there was concern about the practitioner when they submit their reimbursement, putting their home address, because they were doing all their telehealth delivery services from the home, and having their home address particularly potentially accessed from by the public, just because of like data dumps and stuff like that. And CMS did say that, well, if you have like a clinic or a business address, you can use that even if you did the service from the home as well too. So I don't know if that's what you were referring to. But that extension is something, a waiver that CMS did that is supposed to last through the year. So it's not dependent on the March 31st congressional mandated waivers. What is definition of mental health services? We have LCSWs, MDs. So for Medicare, it's specific services. They do not do a definition for mental health services. It is a specific list of services. And again, I don't have the link for that, but if you Google, Google's your friend here. If you Google CMS eligible telehealth services, it will take you to that page where you will see the 2025 list. CMS has a specific list of services that they will reimburse for if telehealth is used. So it is not just like all mental health services. It is a specific list, and that list will tell you exactly what those services are. It's done by CPT or HCPCS code. Can the in-person requirement be satisfied for psychiatric care via telehealth through a collaborative business agreement with a clinic where the patient is seen in person? The way it's written now, no, but, and this is my caveat in here, that in-person requirement has never been implemented. So the way it's written now, I would say no, but I don't know if CMS is forced to implement it, if they may write out further instructions. So that's a stay tuned. And some of these things, like that prior in-person visit, like some of the other stuff as well, are policies that are there underneath the permanent policies, but they have not been implemented yet because we've been under this waiver program. So I don't know exactly how CMS will do it. It's one of those wait and sees. Yeah, there's like a lot of moving pieces, a lot of uncertainty, even with like, the deadline, if it happens and things expire, still a lot of uncertainties because a lot of these policies have not been implemented before. So we just don't know how they're going to do it. We're posting a question by Tammy Howard. Who are the people making decisions? Well, we talked about that. Does this mean specifically that provider or in-person visit with that facility of providers? I'm not sure I understand that question. I will take one more question because I think we're at the top of the hour. Do these policies apply to Medicaid covered mental health services? Again, no, they don't. These are for Medicare services. One other caveat I talked about, I said like this will not impact Medicaid policies immediately, like April 1st, like it would if on Medicare when they expire. However, there is a lot of stuff, a lot of other policies, particularly around the budget, that are going on and talks right now that could impact Medicaid and thereby impact the telehealth policies for the Medicaid program. So that's like another factor to keep in mind as well, too. The Medicare expiration date themselves probably not going to impact Medicaid immediately, though they may copy a policy later on down the line there. However, we also have this other factor of like telehealth of the federal budget and how that may impact state Medicaid programs, and by that also impacting telehealth policies as well too. At the top of the hour, I talked a long time, Cara. My apologies, but I give it back.
Not at all. Thank you for talking a long time. We all really appreciate it. You are such a fount of knowledge and such a great resource. So thank you so much for again coming back. And yes, we do invite you every year because so much is changing and you're such an expert. And so we really appreciate you coming back every year as well. Thank you, everybody, for joining us today. As you can see, May, you're getting lots of hearts and love and applause and things like that floating up. So much appreciated. And folks, as May pointed out, there is a telehealth resource center that she manages, and you do have a place on there you can submit a question for technical assistance. And so we encourage you to visit the website if you have further follow-up questions. So thank you, everybody. Have a lovely weekend and hope to see you next month.